Hey everyone, welcome to your next lecture for the immune system portion of your curriculum. Today we're going to be looking at autoimmune disorders, essentially when your body attacks itself. Now, a quick disclaimer, there's nothing in this lecture that is extremely high yield in the same sense as you might think things like head and neck anatomy or pelvis anatomy are high yield. But I recommend making yourself at least a couple of summary diagrams for this topic because essentially you're just trying to make sure you know some of the quick word associations and buzzwords so that when you see them in an exam, you're able to quickly figure out what condition it is, what type of hypersensitivity reaction you're dealing with, as well as some of the major autoantibodies and associations that are involved. So these slides, I would say, are a bit more detailed than you need to know, but they should give you a good platform to be able to make your own summaries. As always, if you do have any further questions or queries, there are some things that I may have left out because they're not as high yield, but you can find them within my notes that I've linked to the PS Platypus Drive. But without any further ado, let's begin. Okay, just a quick meme to get our blood flow going. Again, autoimmune disorders, we know that there are conditions in which your body's immune system is inappropriately attacking its own host tissues. So there's this idea of autoimmunity and tolerance. Autoimmunity, as we all know, is an immune response that's generated against self-antigens. So it technically is a form of hypersensitivity, but instead of attacking, pathogens, it's attacking a host tissue. Tolerance is kind of the opposite side of the coin. So tolerance is when your body makes sure that it's not attacking itself. So it's protective mechanisms to avoid autoimmunity. So in other words, it's failure of adaptive immune system to respond to self-antigens, so making sure it doesn't attack itself. And that occurs mainly through the VDJ recombination system, which I may have touched on very briefly in our previous lecture. But just to give you a bit of an overview again, it is the system by which you get a lot of random variations in your antibodies and the different types of cells that you're producing within the adaptive immune system. So that's the VDJ system. However, because it's so random and it's so variable, we want to make sure that the things we generate are not going to then inaccurately attack our own host tissues. So some of them will definitely be autoreactive to begin with and lead to autoimmunity, but we have two main mechanisms by which our body makes sure that this doesn't happen. So that is your central and peripheral tolerance mechanisms. So starting off strong with the central tolerance mechanisms, essentially it's a way to ensure that those self-reactive lymphocytes just get destroyed while they're being generated. And within the thymus, it happens for T cells. Within the bone marrow, it happens for B cells, essentially where they're produced. And the process is essentially 4 steps. First, the lymphocyte is tested against a number of self-antigens to check for the self-reactivity. As soon as you have some sort of self-reactivity, so that lymphocyte finds and latches onto a particular antigen, which is a body antigen, and it launches an immune response, the body knows this is not going to be something that we can release off into the rest of the system. So it will then be systematically removed through a process called clonal deletion, which is just killing it off. What this means is now you have a smaller pool of mature but still non-self-reactive naive lymphocytes. So it's a smaller pool, but it's at least a pool that won't attack itself, right? Or attack the host body. And then all of these will undergo clonal selection. So that smaller pool of individual variable lymphocytes will then mature and then expand off. So they'll keep reproducing until we have a massive pool. And these are the ones that are expected to respond to any antigens that are not present in the body. However, this process is not enough because only the very high affinity cells will be removed. In other words, if you do have some cells which have a slight, like partial affinity towards the self antigens, they won't be removed because this process is specific to things that have a very strong attachment. So the reason why we have this sort of exception is that we want to make sure that at the end of the day, we have a very, very strong cell pool that can then work towards a strong immune system. We don't want to kill everything, right? Even if it has a low affinity, we don't want to just immediately say, this is a problem. We need to have other systems to then kill those off later on down the track when they become a problem. So hopefully that makes sense. And that explains why we need a separate layer called our peripheral tolerance mechanisms. Now, essentially here, there's a lot of terminology to remember, but if you try and break it down and perhaps give yourself some examples to work with, it remains a little bit easier. So for this one, we're trying to get rid of those leftover low affinity self-reactive lymphocytes. And there are four main ways you can do it. Well, you can see on the right-hand side, there's a lot more, but four main ones that are discussed and worth knowing. The main important one is antigen segregation. So essentially just physical barriers that make sure that where there are sites where having an immune response is actually going to cause more harm than good. We want to make sure that an immune response is very difficult to launch there. So for example, in the eyes, the testicles, and the brain, right? You can imagine if you have an inflammation reaction there, it's probably going to cause more damage. So you have those physical barriers. For example, with the testes, you have the brain-testes barrier. With the testes, you have the blood-testes barrier, not the brain-testes barrier. That would be a bit strange. Then you've got the peripheral energy mechanism. So it's deactivated. Any lymphocytes are deactivated if it engages with an antigen-presenting cell that lacks co-stimulatory signals. You have regulatory T cells, which inhibit self-reactive T lymphocytes via suppressive cytokines, and then activation-induced apoptosis. So essentially, any chronically activated T cells are recognized and then killed off based off the fact that they've been activated for too long. So these four mechanisms, plus the central tolerance we discussed, hopefully tries to strike the perfect immune balance between an effective immune system, but an immune system that's not going to then wreak havoc on everything. So that's the main reason why we have these two. But of course, we're here today because there are some ways by which these systems go wrong, and we end up with a patient who has an autoimmune or multiple autoimmune disorders. So there are two main, because it's such a multifactorial condition, and not everyone knows the full picture around autoimmunity. You can try to kind of think about them as genetic factors that contribute and environmental factors that contribute. So some of the genetic factors that contribute, the main one to remember here is the HLA protein, so the HLA serotype. So certain HLA alleles, when you can test for them in a patient, they tend to be associated with an increased susceptibility to some of these autoimmune conditions. They're essentially MHC1 receptors, which we might have learned about back in year one. Not really important here to know that it's an MHC1, but essentially it presents antigens to the T lymphocytes. However, some of these alleles may not interact with certain self-reactive T lymphocytes. In other words, that sort of reaction we had at the beginning, where we have the central tolerance mechanisms, whereby those alleles those antigens are presented to the T lymphocytes, and then they get killed off if they react to their host tissue. Because these particular receptors are messed up, they're not going to be able to recognize that, oh, wait, this is a self-reactive T lymphocyte, and those cells will therefore be allowed to persist. So there are a lot of different HLA serotypes, as you can see on the right-hand side. By no means do you have to remember any of these, unless I kind of specifically talk about it in the next couple of slides. But it's just to show you the variability and the fact, as we'll get to in a couple of seconds, that's not all of these act in the same way. So for example, in ankylosing spondylitis, B27 has a relative risk of 87 times, whereas something like, for example, rheumatoid arthritis, the DR4 HLA allele only by about 4 times, which is still significant, but it's very variable. And also there's a, what they say here is a sex ratio. So in other words, some conditions would tend to be more common in males, some conditions more common in females. So that's gender bias. But overall, it seems to be that most autoimmunities develop in female patients more than male patients. Again, the reasoning behind that is a bit uncertain. Family history is also potentially contributive. So you can have some conditions that run in the family, and there have been strong correlations in twin studies. Something like type 2 diabetes or something like that could be an example. Single gene defects as well could be a potential reason why you end up with messed up immune genes. So some examples here are AIRE, FAS and FASL, and FOXP3, which I think you go over in a lot more detail in subsequent lectures. Not all of these, but I guess it's just here to give you an example. By no means do you have to remember any of those names, but just know that those examples exist. Environmental factors are probably a little bit more important. These ones are actually really interesting. If you want to kind of look into these further, I would recommend it, especially in the lecture. They go into it in a lot of detail. I've also got a picture on the next slide, which actually shows each of these, but I'll first explain it in words, and then you can have a look at the pictures to supplement. So the first one is breaching immunologically privileged sites. So remember how we had those mechanisms by which really important organs, which we don't want to be damaged, have a barrier to prevent immune reactions to bleed into those regions? Well, sometimes they can be broken, right? So a classic example that is really interesting is the idea of sympathetic ophthalmia. So essentially the process is you have trauma to one eye, which breaks the barrier in that eye, and then allows access. So the antigens within the eye actually kind of they're exposed now, right? So now the T cells that are circulating in the blood, they can go into the eye. They haven't ever had exposure to these antigens, right? Because they've been exposed forever. They've been separated off forever. So they think that this is actually a foreign antigen, when we obviously know that the eye is part of our body. But the immune system doesn't care. So it sees it as foreign, carries back the antigens to the lymph nodes, which activates T cells. T cells then return to the bloodstream. And this time they don't just go to the eye that they found those antigens in. Now they recognize that, this is probably going to be present in the other eye as well. So they can now break into both of the eyes and attack both of those antigens, because essentially they're the same. And then it will lead to blindness progressively over time. So it's a very interesting sort of pathophys. Then you've got stress-induced post-translational modification. So in rheumatoid arthritis, this is super high yield. So you have a few genes that could be responsible and lead to enzymes that citrullinate normal proteins. And those normal proteins are typically in rheumatoid arthritis found within the joint spaces. So they citrulinate them. And because they now have been modified in a sense, although they were normal proteins to begin with, now your body thinks that they're completely different because they now have additions on them. So the T cells think they're foreign and then launch an attack. And that's how you get rheumatoid arthritis in a very, very simple way. And it is known that sometimes those enzymes that citrullinate certain proteins, they're increased in expression with smoking and stress. So risk factors for rheumatoid arthritis, when you study this like really in detail, you will see smoking and stress in there. And this is proposed to be the reason why. Infection and molecular mimicry, classic example is rheumatoid heart disease. I think you would have covered this in microbiology of cardiovascular system. But again, just to refresh your memory, when you have antigens on pathogens that are similar to self-antigens, you can get cross reactions. So the classic example is streptococcus. So you have group A beta hemolytic streptococcus specifically. The antigens on streptococcus, for some reason, are very similar to the antigens that are present on the heart valves. So the antibodies that are produced against the bacteria can also attach to the heart valves, and then your body, because it doesn't really see what the antibody is attached to, it just attacks anything that is flagged for destruction. So it's going to attack the heart valves and lead to all sorts of valvular disease. Other kind of examples, some interesting ones are Klebsiella pneumonia and ankylosing spondylitis. And something you will learn in third year is the Campylobacter gastroenteritis, which is responsible for a condition called Guillain-Barré syndrome, which affects the nerves. And then finally, another really emerging area is the hygiene hypothesis. So it seems that if you look at a distribution across different countries, areas that have a higher rate of infections seem to also have a lower rate of autoimmune disease. So it's proposed that maybe early exposure to infection, while it might seem counterintuitive, it actually trains the body to avoid kind of attacking itself, because it sees so much variation that it knows exactly when to not attack itself, if that makes sense. But again, it's probably not going to make sense because it's not something that's been researched very well, and it's a developing area. So you've got genetic and environmental factors. And here you've got some really good diagrams to kind of explain each of those concepts if you'd like to have a look. Okay, let's get into the meat of this particular lecture, which is the actual conditions. So firstly, type 1 diabetes. That's the one that is autoimmune response against beta cells of the islet of Langerhans, which is found in the pancreas. We know the beta cells secrete insulin, and this is a type of type 4 hypersensitivity reaction. In other words, you have immune complex formation, and it's what you would say is a delayed hypersensitivity. How does it happen? Well, you have cytotoxic T cells, so the CD8 T cells, which target beta cells within the pancreas. And there's also some CD4 cell contribution, but it's mainly the CD8 cytotoxic cells. The autoantigens that are actually things that the body attacks can be insulin itself, or it can be other things like tyrosine phosphatase, which is a protein, and the IGRP protein. Interestingly, the autoantibodies are actually produced in this process, but they don't actually do anything. So your body produces autoantibodies against the autoantigens. So beta cells produce them, B cells produce them, but they don't actually attack anything. But we can still use them for diagnosis because when we detect them, we know something's up. So it's a very interesting sort of conundrum. And what happens is you get progressive leukocytic infiltrates into the islets. It takes many years for symptoms to actually develop because you need your beta cell numbers to fall dramatically. Because initially what happens is that your beta cells that are remaining compensate by producing even more insulin up until the point that they become very fatigued and then start to die off themselves. While you do have some Th1 cells, so those CD4 cells I was mentioning before, and they do drive a little bit of inflammation, it's mainly the cytotoxic lymphocytes that are doing the killing of the cells. So they're the ones of interest. Without any treatment, as you would expect, you would get chronic hyperglycemia, which has a lot of different manifestations, mainly renal failure, blindness, and also an extremely high incidence of cardiovascular disease. So you would expect in a patient with type 1 diabetes mellitus, when they have an absolute deficiency in insulin, you need insulin replacement for life. Okay, what about rheumatoid arthritis? We kind of talked about this very briefly already. It's a type 4 hypersensitivity again, so immune complexes, much more common in females, and it tends to peak at about 35 to 50 years, so in middle to older aged people. What you have is a formation of a pannus, which is just a fancy way of saying infiltration into the joint space. A lot of stuff happens. You don't necessarily need to remember this, but fibroblasts are activated by macrophages, which release TNF alpha, which then produce MMP. I think that was metal metalloprotease or something like that. So it's essentially an enzyme that breaks down some of these really important structures within your joint space. And it also releases rank ligand, which activates osteoclast. So in other words, all of these are going to erode the matrix proteins, the cartilage, as well as the bone, which is leading to the arthritis. It is associated with HLA proteins, as we saw previously. And some of the autoantigens that your body is reacting against include collagen, proteoglycans, vimentin, and heat shock protein. A lot of these are actually citrulinated, but you have other proteins which undergo citrullination. What we use for diagnostics is something called an elevated level of rheumatoid factor, which is an anti-IgG protein, and it forms part of an immune complex. So that indicates that RA may be partly type 3 hypersensitivity, but mostly it's a type 4 hypersensitivity, and rheumatoid factor can be used as a biomarker. There are no cures for rheumatoid arthritis at the moment, but there are many, many medications you can use to try and target some of the cytokines that are made. So there's a lot of medications here. I haven't gone through a huge number of them. That's not the important part. So things like methotrexate, that kind of thing. But one really important one that is stressed in the lectures is something called infliximab, which specifically targets TNF alpha, which hopefully will slow down the disease process. SLE, so systemic lupus erythematosus, is a type of type 3 hypersensitivity, and it's caused by circulating immune complexes that are composed of DNA and alpha DNA antibodies that target DNA. So the main thing to remember here is that you have a classic red butterfly rash on the face and the cheeks. So you can see that in the image over here. You can see that it's called a malar flush. Most of these immune complexes, they lodge within the vessels of the kidney as well as just generalized blood vessels. So you can get things like glomerulonephritis and vasculitis. Because what happens is that once those immune complexes are deposited, they're not able to really detach from there and they get stuck. And all of the immune reaction comes to that site. So you get complement system activation at the site of the vessels and also neutrophil infiltration. So obviously damaging those blood vessels. The pathogenesis here is very, very unclear. But what is known is that there are two molecules that do contribute. So TLR9 and BAFF. And I've gone through kind of like a stepwise process of what sort of things happen, but I don't think that these dot points are really that important to understand. I think if you're thinking about major things to know is the classic presentation, just in case they don't straight out tell you that it's SLE, they just say it's a patient with a butterfly rash. You should know that's SLE. And if they have manifestations like glomerulonephritis or kidney problems and vasculitis. And also remembering the kind of antibodies that you could be testing for. So anti-DNA or alpha DNA antibodies, as well as associations with TLR9 and BAFF. The main way to treat these is with corticosteroids and other biologic medications. Myasthenia gravis is an interesting one. You don't need to know too much here. It's a type 2 hypersensitivity where you get antibodies against the N cholinergic receptors. So you would have covered the different type of cholinergic receptors back in first year. You have the M and the N. These ones are responsible for allowing signals to be conducted across neuromuscular junctions. So if you're blocking those, you're preventing acetylcholine from then triggering muscle contraction, which leads to paralysis. Three main ways that your antibodies do this. One is that they destroy the postsynaptic muscle membrane, so then you have nothing to bind to. They can modulate what happens at the postsynaptic membrane. So antibodies trigger endocytosis and therefore destruction of receptors, because your body realizes that antibodies have attached to those receptors, they're not going to be of much use, so let's destroy them. They can also antagonize, so essentially binding to them and preventing acetylcholine from attaching, as we mentioned before. So the main things you get are muscle weakness and fatigue, but also the classic presentation of a drooping eyelid. Of course, drooping eyelid, there's a lot of different causes that you need to consider. But at this stage, for myasthenia gravis, the main classic presentation is the drooping on the eyelid. Graves' disease is something I think you would have covered already in a huge amount of detail. So this is just mainly focusing on the autoimmune aspect of it. So it's a type 2 hypersensitivity. You have auto antibodies against the TSH receptor on thyroid cells, but it's actually a stimulatory antibody. So it actually stimulates excessive and unregulated production of thyroid hormone. So it's a bit of a special case. Some of the things that it can lead to, the most prominent feature is exophthalmos, or bulging of the eyes, which can be really, really extreme in some patients if it's untreated. Interestingly, those antibodies also have the ability to cross the placenta. So that can also lead to Graves' disease and hyperthyroidism in a newborn patient. So that's all the content there is for autoimmunity. I hope you found that quite useful. I've tried to be purposely quite quick with this presentation because in the grand scheme of things, not all of it is super high yield, but I think it's still good to know some of the major associations just in case they do come up in an exam. So best of luck. I'll see you in another lecture. See ya.